all right? So what's the difference between X-ray and CT? The difference is that an X-ray will give you a 2D image, but a CT will give you a 3D image, right? All right. All right. So you're going to be able to differentiate structures better. You're going to be able to localize them better, right? So if you look at this X-ray right here, you can see that there's a mass right here, right? But you can't tell if the mass is in the like in front of anterior in the lung or posterior in the lung. You're not sure which lobe it's in. You're not sure if it's compressing any vessels or any other major structures. You simply can't tell because you only have a 2D image that is relatively poor in contrast and in spatial resolution. But if you look at the CT of the same image or the same patient, you're going to be able to localize it like exactly where it is, and if it's compressing or invading into any other adjacent structures, right? So yeah, that's the main difference between CTs and X-rays. That CT will give you a 2D image, while an X-ray will give you a 2D image, while a CT will give you a 3D image. CTs use X-rays, see, same thing I said, right? The only thing is that X-rays will give you a single projection, but a CT will give you multiple projections to give you the 3D image. Same slide from yesterday. All right, so in a normal X-ray, right? So this is the X-ray tube right here, right? So in a normal X-ray, you're gonna have one detector and you're gonna have one X-ray tube, all right? And it's true, you have here one X-ray tube, but you have multiple detectors in a CT, right? So you're gonna have the X-rays coming, what's known by projection? Like a single projection, I mean like a single view. Think of a projection as view, right? So you get one view when it comes to X-ray, while with CT you get multiple views, right? So as I was saying, you have an X-ray, you're welcome. As you can see here, an X-ray tube, right? Just like in an X-ray machine. But the difference is you have multiple detectors, right? So you have here, you have multiple detectors right here, detecting the X-rays coming from the X-ray tube. And one more thing is that the X-ray tube keeps moving, all right? So 1 second it's here, the other it's here. It just keeps moving around the patient to give you multiple views, all right? Now the multiple views come from the movement of the X-ray tube. That's how you get the multiple views or the multiple projections that you see in a CT scan. The multiple detectors will give you better resolution, right? So the more detectors you have, the better the resolution is. Because if you remember yesterday, remember the thing about I said about pixels, right? The more pixels you have, the smaller they are, the better. It's the same concept right here. If you have more detectors and each detector is smaller in size, the better the resolution is, right? This is just same thing, right? Showing you that you get a view from here, and then it moves and gives you another view from here, and then it moves and it gives you a third view from here, right? And then at the end, you're going to end up with 3 views, right? This is just an example. In reality, you get much more than just 3 views, right? This is just an example. So at the end of the day, you get 3 views right here, and then using a computer, what will happen is that a software will merge those pictures together depending on the attenuation, all right? So it will match each attenuation with each other, all right? And it will give you a matrix. And a matrix is basically the end product or the end image that you see on a CT scan on the computer screen. The matrix is the final image, right? That's why it's called a computed tomography, because the computer is the one that gives you the picture or gives you the view, the result. Right, so the multiple views you get from the X-ray tube as it keeps moving will be merged together to give you a matrix, right? And this is basically what you see. You will get this, all right? All right. So how the image is formed, it's formed by a software, all right? It's formed by a computer. Now, If you go back here, see, this is the same X-ray tube, right? It's just moving. So when the X-ray tube is right here, it's going to give you a view that is like this side of this patient, right? And then when it goes to the middle, it's going to give you this view of the patient. And when it goes to the right, it's going to give you this view of the patient. And you will end up with 3 sets of views, right? Or 3 sets of pictures that at some point are overlapping, because you see this part right here. This part is overlapping of this picture and this picture. So this part is overlapping. So if you get the pure raw pictures that the CT scan image or the CT scan machine gives you, is going to be distorted because there's a lot of overlap going on. But what happens is those 3 images or those 3 views are fed into a software or fed into a computer. There's one X-ray tube and you have multiple detectors. So if you go back here, can you see those small cubes? Each one is a detector, all right? So you have one X-ray tube, but multiple detectors, all right? So what happens is those 3 views are fed into a software, and a software, yes, the detectors move too. So like they are always the opposite side of the X-ray tube. So if you can see, the detectors are all set on like a piece of metal or whatever, right? And they keep moving in relationship to the X-ray tube. So the X-ray, I don't know if my hand will show it. So they just keep moving together. They move together, right? They're not independent. So if this goes to the left, this will go to the right. So it can detect all the things coming from the X-ray tube. You're welcome. So as I was saying, you have 3 views that you got, right? So you have 1, 2, 3. You have 3 views, right? What happens is that those 3 views are then fed into a software or a computer, right? And that computer will merge those views together, all right? They will merge them together, eliminate any overlap in the picture, all right? Improve the resolution to give you the final end product, which is the matrix. And the matrix is basically a combination of all the views that the CT scan or the X-ray tube took. And this is the result that you get, all right? And again, that's why it's called computed tomography, all right? Because the computer, it's computed. The computer is what gives you the final image, all right? It's not like X-rays, you know? Like you don't need to pass your X-ray image by a software or a computer to give you the image, right? You can get it simply by a film. You don't even need that a computer to process this, but in a CT you do. Now, do you guys have any questions about what I discussed up until now? All right, great. Now, same concept as yesterday. You have the spatial resolution, you have the contrast resolution, you have the temporal resolution, all right? Now, before I skip this, because I explained it yesterday, does anyone want me to re-explain this? Because it's all right, I can do it. Okay. All right. So just again, did we do scan time? No, I'm gonna go through it. Scan time is not that. Yes, spatial resolution is basically the pixels part of yesterday's lecture. If you remember that, that's spatial. And as you can see right here, pixels, right? No, we did not do scan time. I'm not sure if it's explained, Aslan. Yeah, it's not explained. But scan time is I don't know how to explain it because it's not a good thing. Scan time is not a good thing. These slides, anything you can focus on, because I'll talk about what you should focus on right now. Scan time is a bad thing. That's basically it. But your professor didn't really explain it. I'm not sure if I should. It's going to be a waste of time. But it's a bad thing. You need to minimize scan time. That's basically what all you need to know. All right. Now, what I want, what is it about generally? It causes distortion in the image. It causes, because anything that leads to an artifact is something that should not be there, right? And basically a scan time is the longer you scan the patient, all right? the more possibility this patient is going to breathe, the more frequently the patient is going to breathe. And by breathing, you move. And when you're moving inside a CT scan, that distorts the image. So you want to minimize the scan time. So you minimize the breathing artifact. An artifact is a bad thing, all right? It distorts the image. You're welcome. So what do I want you to focus on? Honestly, like right here, the only thing I want you to focus on is that you have one X-ray tube, and you have multiple detectors. And that's the difference between a CT and an X-ray. You have multiple detectors, right? And you need to know that the software is used to give you a CT image. It's not something natural like an X-ray. That's basically what I need you to focus on from all those slides, right? Now for spatial resolution, as I mentioned yesterday, those are pixels. The smaller your pixels are, the more pixels you have, the better the spatial resolution, all right? I go in depth about this in yesterday's lecture if you want to go and watch it on the YouTube channel. Yep, exactly. They have the same thing. You have general and characteristic radiation. It's the exact same radiation you get from an X-ray, all right? You're welcome. So if you can see here, a detector size that is 7.5 millimeters would give you what you can see right here, all right? But if it's smaller, and as I said, the smaller it is, the more detectors you have, the better the resolution is. And you can see the difference here. This has a big detector, this has a small detector, and you can see the difference in the images, all right? Again, the number of pixels, as I mentioned, the more pixels you have, naturally, the smaller they are, which leads to a better picture. All right, now this is the different part about this lecture. This is what's different between CT and X-rays, the attenuation, all right? And by attenuation, I mean how differently different parts of the body absorb the X-rays. And in attenuation, in CT, we measure it by the Hounsfield units or the HU units, right? HU. You can't say HU units because U is units, right? So your benchmark is water, which is 0 HUs, right? This is your benchmark. This is where you start. What's less than water? Air. And air would be less than 0. So it's going to be -500, -1000, depending on what type of air there is. And then everything else is just higher than 0. You have muscles, bones, fatty tissue, whatever. It's going to be always higher than 0, right? Because the only thing that is 0 is water. This is just a slide here it's just a picture to show you the different HUs in different parts of the body. As you can see here, lung would be on the -50, all right? Because it's filled with air, right? Fat is a special case or a special situation. It's not really that negative, but it is on the negative side, all right? So if you put it in contrast with air, it's going to appear darker than air, all right? Sorry, water. It will appear darker than water. No, you don't have to. I'm just giving you an example of like how things absorb X-rays differently, right? All right. Contrast resolution, how is this different from X-rays? It's not different, it's just we quantify it in CT. In CT, we quantify it. We care how much X-rays different types of the body absorb, because later on, I'm gonna talk about window. And window is important because that's where we use Hounsfield units. In X-rays, we don't care how much bone absorbs X-rays, but here we do. Attenuation depends on different parts of the body. So like your bone will absorb a lot of X-rays, right? So it will attenuate more and so on, right? So it depends on the density of the tissue. All right. So a window setting is the center. Okay, so let's say you have a chest CT, right? And you don't care about the bones, you don't care about the heart, you care about the lung. You're scanning this chest only for the lungs. So what you do is you set the CT scan or the CT settings on a lung window. And I'm going to explain to you what a lung window is and what different windows mean, all right? But basically, when you get a CT scan, right? You're going to have bones, and bones are 1,000 HUs. And you're going to have the lungs, which is -100 HUs. And then you're going to have the heart, which is 200 HUs. So you have a wide range of tissues, with wide ranges of HUs, right? And you don't care about a lot of these. You only care about the lungs. So what you do is you eliminate everything that is outside the Hounsfield units of the lung. So let's say the lung will appear between Hounsfield units of -50 and -200, all right? Anything less than -200, you eliminate, and anything more than -50, you eliminate, all right? So that you end up only looking at the lungs. And that's what a window is, all right? So let me show you. This is just, again, same thing, same thing. All right, this is a lung window, all right? So if you notice, guys, look at the chest wall, right? You can't see anything here. You can't, like, even if there was a pathology here, you wouldn't be able to differentiate it from anything. And so is the bones. The bones. Yes, of course, all right? And that's why okay, so let's say you have normal lungs. Normal lungs on a lung window will all appear like this part right here, right? Like they won't appear, like they will all have the same color of this part right here, because this looks healthy to me, right? If you have anything else inside the lungs that is distorting the lung or affecting the lung or inflaming the lung, it's going to give you a different attenuation. So I want you to look at this part right here. See how this part is brighter than this part, for example. See, this is telling you that there's something wrong, right? There's some sort of infiltration in the lungs, and this is actually pneumonia, all right? So the lung would appear uniform in color in the lung window, all right? And to detect any abnormalities, right? And let's say those abnormalities are very subtle, they're small. If you want to really see them, you're gonna have to set it to a lung window, because in lung window, everything else that does not have to do anything with the lung is eliminated, all right? So nothing is really distorting the view anymore. It's just the lung and whatever is happening inside of it, all right? So for example, here in the lung window, we usually put the ranges between -400 and -600, all right? And that's how you view the lung window. The window width wasn't it wouldn't distort your view. You will still be able to see the lungs, but if there's any subtle pathologies inside the lung, there's a chance you will miss them, because now you're not focused on the lungs, you're focused on everything, all right? But when you're focused on the lungs, any small or subtle changes in the lung will be more obvious. All right, you got it. Your professor didn't talk about the window width, all right, as far as I remember. So I'm not going to really dig deep in that. It's going to be a waste of time. This is just another example of a mediastinal window. In a mediastinal window, you focus on the soft tissue structures inside the thorax or inside the mediastinum. This includes the pulmonary artery, aorta, the heart, and stuff like this, all right? And here, you want to eliminate everything, right? So what you do is you put the level on level 50. Remember what we said about the lung? It's -200 to -600. When you put the level on 50, the lung is eliminated. It's gone, right? Because you put the level on 50. So -200, -600, all of that is eliminated. It's gone. So if you look at the lungs right here, black, darkness, you can't see anything, all right? And you can see the bones, right? But if there's a fracture in this rib right here, or a fracture here, you're not going to be able to see it, because the bone window is much higher than 50, and you eliminated that too, all right? So what you only can see is the mediastinum and all the mediastinal structures, and that's it. No, you don't have to memorize the ranges. It's just to further explain to you how the window works, but you don't have to memorize the windows. You're welcome. All right, you have the liver window. Again, same thing. It's just to focus on the liver. A bone window, see how higher the bone window is? It's on the 400 HUs, right? So everything else below 400 is eliminated. So all the soft tissue, your brain, your mucosal membranes, everything, this is a head CT. Everything is eliminated. You can only see the bones, and you can see details of the bones, right? Iodinated contrast, intravenous contrast aims to max the contrast resolution. Remember, if you guys remember yesterday's lecture, as I said, you give contrast, all right? Because the KV or the KEV it releases is way higher than everything else, right? So it's going to be starkling white. It's just going to be very white. So it's going to give you a perfect contrast with anything that is darker than it on the side, all right? And you can see here, like, if you look, this is the pulmonary trunk or the pulmonary artery, right? And if there's anything inside that pulmonary artery that is distorting it, like an embolus or something, you're going to be easily able to see it, because the difference between this sparkling white and that tiny small speck of black is going to be way more obvious when you put contrast. All right, this is basically the same thing. It's just telling you again that the photoelectric effect is increased with a less KVP, if you guys remember from last night. But yeah, again, same thing. The KVP has an exponential relation. So if you double the dose of the KVP, you quadruple the energy. And it tells you that the MA is a linear relationship. So if you double the MA, you double the energy. And tube on time. So basically, the longer the patient is inside the tube of the CT scan, the higher the dose. That's basically it. There's nothing else in this slide. What is FOV? I'm not sure. Not sure what FOV is. Want to Google it? Let's Google it real quick.
It's field of view.
Oh, nice. All right. I believe that a field of view, okay, so what they mean by field of view here is that, do you guys remember the slit I talked about? That's basically, I think that's what they're talking about. That the more surface area the patient is exposed to radiation, right, the higher the dose. So if you increase the area that the patient is exposed to by 10% or 10 centimeters, you increase the dose by 10%. I believe that's what they mean. You're welcome. And that's the end of this lecture. All right, that didn't take long, 29 minutes, not bad. You guys want to take a break before we go into the bigger lecture, or is there? Oh yeah, there is. Yeah, tube on time is explained, KVP is explained, MA is explained. I don't think FOV is explained. It's not important, it's just an explanation. Like if you, yeah, as a matter of fact, FOV is reduced by 10 centimeters. Is reduced, yeah. See, if you reduce it by 10, you reduce it by 10%. If you increase it by 10, you increase it by 10%. The notes are there to explain, right? So if you understand what's going on, you're good. Like, it doesn't add anything really. Exactly, Ahmed. All right. Just focus on what you need to get a picture of. Don't you know, diverge. All right, guys. Do you want to take a 5-minute break before we go into the bigger lecture, which is the clinical applications of CT, or do you want to just dig into it? Right. All right, let's take 5 minutes. Let's take 5 minutes, right? Okay, guys. See you in 5 minutes. All right. I have, all right, so the CT applications, right? It's kind of short, the lecture that you guys took. I have another lecture that I edited on, and I added more clinical stuff, ways to better understand what you guys are seeing. Do you want to do that? But it's going to be shwaya longer. It's almost 50 slides. What do you just want to stick to the lecture that the doctor gave you? Whatever you want. I'm chill with both. All right. All right. Cool. All right. I hope it will. Inshallah, it will. I think it's this one. No, this is the one that the professor gave you. Yeah, that's the one. Now, before I start CT, the applications, I need you guys to remember something, and something that's very important. If she's pregnant, don't order CT or X-ray. Just don't. right? And if your only options are CT, make sure that this patient has a shield on her abdomen. Okay, so just keep that in mind. It's going to be easier for you guys in the exam because it helps you eliminate options. It helps you eliminate choices. All right.
This is the outline. We will start by reviewing basic anatomy of various.
Oh, that's a lecture. All right. All right. So keep that in mind. Okay. Now let's start. This is just more stuff. Okay, so indications for CT scans. Here in Saudi, I'm not sure about the US really, but here in Saudi, in trauma patients, especially in the ER, so like motor vehicle accidents and stuff like this, we usually tend to order a pan CT scan for these patients, all right? So a scan for the whole body. That's why it's called a pan CT scan, all right? So keep in mind, trauma patients probably will get a CT scan. All right. Now, if you want to visualize the abdominal organs, since most of them are soft tissue, right? An X-ray will not be that helpful. Like it could be helpful, but it's not really that good. So usually we do CT scan for abdominal organs. For the lung parenchyma, so patients who have COPD, lung fibrosis, sometimes people with lung cancer, stuff like this, they get a CT scan, right? In stroke patients, they always get a CT scan, always, right? If you suspect if you suspect a stroke, get a CT scan. And for CT angiography, this is when you want to visualize the coronary arteries of the heart, right? This is done when you want to maybe stent an artery for a patient who's having an MI, for example, all right? So keep that in mind. Now, CT in trauma, as I said, brain CT and spine, chest, abdomen, pelvis. All right. So for CT, why do we get a CT scan in stroke? Like what are you trying to see in a stroke patient when you get a CT scan? All right. You're not trying to see a stroke. Exactly. All right. Exactly. It rules out hemorrhagic stroke. You're not trying to see the infarct. You're trying to see if there's bleeding or not, right? And that's the only reason you use brain CT in a stroke patient, right? You use it to rule out hemorrhagic transformation or hemorrhagic stroke in the patient, all right? That's why we use it without contrast, because you don't need contrast. If there's blood in the brain, it's going to be obvious, and you don't need contrast. Now we use chest, abdomen, and pelvis get IV contrast because usually it gives you a better view of these organs. Right? Now, clinical applications of the CT. All right. So pelvis. What about the pelvis? Yeah, and the pelvis. What about like the reproductive organs? Reproductive organs and the bladder too. Don't forget the bladder is also in your pelvis. Right? You're welcome. So in acute conditions, you got a CT for any patient who has signs of headache with an increased intracranial pressure. What are the signs of increased intracranial pressure? Because not everyone who says I have a headache gets a CT or gets an MRI. No, only patients who have signs of increased intracranial pressure. So signs of increased intracranial pressure would probably be something like papilledema, right? Papilledema is when you do a fundoscopy or an examination of the eye, and the optic disc becomes engorged and has poor demarcations, right? Vomiting is a sign of increased intracranial pressure. Nausea is a sign of increased intracranial pressure, and so on, right? So these patients get a CT scan. Any patient who has a neurological deficit, so suddenly he was sitting there not doing anything, and suddenly their right hand became weak, right? And they start slurring, and they have drooping of one of the eyelids, right? Those patients get a CT scan. What is DOB? Date of birth? What does your date of birth have to do with anything? Oh, difficulty breathing. All right. Difficulty breathing is not, CT is not the first line or not the first line imaging for shortness of breath. It's actually chest X-ray. But yeah, you can get a CT for those, especially for patients who have maybe a foreign body, maybe if they have a tumor that's compressing on their bronchus, stuff like this. All right. For abdominal pain, a CT is done for any signs of ischemia of the colon or the small bowel. It's done also for bowel obstruction and obviously trauma, as I mentioned. All right. And then everything else is non-acute. All right. As I mentioned, contraindications with contrast. It depends on the situation. So, for example, in abdominal pain, yes, you would get contrast, right? If you in neurological diseases like strokes and stuff like this, you probably won't get a CT. You will probably won't give a contrast for that. You're welcome. All right. So, as I mentioned in contraindications, pregnancy is the number one contraindication for CT scans, right? If the patient has allergy to IV contrast, then you can't give IV contrast. And then it depends on your experience as a radiologist if you want to do it without CT, without IV contrast, or just not do the CT at all. That is up to you. Adrenal impairment, again, because of the IV contrast. If you guys remember from last lecture, one of the problems with IV contrast is that it's excreted by the kidneys, right? So if the patient has renal impairment, you might not want to give the patient IV contrast. All right, window. What window is this, guys? It's a bone window. Perfect. Yes. See, everything else is eliminated. You can't see the brain. You can't see mucosal structures. You can't see anything at all. You can only see one thing and one thing only, and that is the bone, right? So that is a bone window. Why do we get this? Why would you need a CT scan with bone window? Exactly, for skull fractures. Perfect. What window is this? We didn't talk about this, by the way. So if you get it, I'll be impressed. You can call it brain window, sure. It is technically brain window, but this is what we call a soft tissue window, right? So keep that in mind. This is a soft tissue window. All right. So nothing really here to show you except that these are different levels of a CT imaging. What else would be soft tissue in the brain? Cranial nerves would be soft tissue, but it's really hard to see cranial nerves. Generally, it would be anything that is actually soft tissue. So your heart is soft tissue. Remember the mediastinal window we talked about? That is also called soft tissue window. All right, just in the mediastinum, and that's why it's called the mediastinal window. It's just personally, at least, I don't know if this is something, but I've never heard of something called a brain window. Maybe it exists. I just never heard of it. You're welcome. All right. Now this slide just tells you that we have different levels, especially when it comes to a brain CT. All right. So this is the highest. All right. Out of all those three, and then you go to the middle, and you can see the brainstem right here. You can see the pons and medulla and whatever, and then this is the level of the eye. You can see the cerebellum right here. All right. So keep in mind that when you see the eye, you're relatively low in the brain structures. All right. When you can see the eyes, you're at the level of the cerebellum right here. All right. And this is the fourth ventricle, right? So keep that in mind. Like if you look here, you can see the lateral ventricles, right? You can see the lateral ventricles, and that's how you know you're up in the brain. Yep. Just see fourth ventricle right here. This is the brain stem. Yep. Nothing really to talk about. What is happening here, guys? Yeah, perfect. So you can see here that there's no edema and there's no hemorrhage. No. All right. There's shrinking. So see, that's the thing. If it's hemorrhage, it's going to be bright. Keep that in mind. All right. If there's hemorrhage, it's going to be bright. It's going to be whitish in color, not dark. What's happening here is that there's atrophy of the brain tissue. All right. So the ventricles and the gyri and sulci are deeper. All right. So they accommodate more CSF. That's why you think there's increased CSF here, but there's no increased CSF. No, it's just the brain tissue has shrunk down. So there's more space for the CSF, right? And this happens in two peoples generally, elderly and, who can tell me the second type of people who get brain atrophy other than elderly? Alcoholics, right? No, not schizophrenia, alcoholics. So people who have chronic history of alcoholism, they will have brain atrophy. Alzheimer's, elderly, right? But yes, you're right. Okay. I saw a question. How will we see edema? Edema will be more localized, more focused about in one area. All right. It's not going to be diffuse like you're seeing it right here. All right. And it's going to be like, if you look closely, you will be able to differentiate between the white matter and the dark matter. When it comes to edema, that differentiation between the white and the gray matter is gone. All right. That's how you know you're dealing with edema. And there's going to be a shifting of the midline. So you can see that the midline is in the midline right here, right? But if you have edema, like let's say on the right side, you will see that the brain is moving to the left side. Even something normal hydrocephalus in terms of being. Hydrocephalus is not edema though. Hydrocephalus means there's increased CSF fluid in the ventricles. So there's no edema. Please have this PowerPoint after. Yes, of course, I'll give it to you guys. All right, so this is one of the slides. You're welcome. Those are one of the slides I did, that I added. All right, this just gives you different presentation, like clinical presentations of each types of brain pathologies. All right. So, for example, in an epidural hemorrhage, these people usually are trauma patients, all right? And these people will probably present with something like loss of consciousness, headache, and ipsilateral mydriasis, right? So I don't really want to go through the whole thing, right? It's just for your own sake, right? If you want to, learn more about this. And I bolded the things that are special to each case. So if you have subarachnoid hemorrhage, for example, you're going to have something called a thunderclap headache. So these patients will tell you, oh, this is the worst headache of my life. Okay. And these patients usually have a ruptured aneurysm, right? And they could be trauma, but ruptured aneurysm. What's AMS? AMS is altered mental status, all right? So they're going to be drowsy, confused, their mental status is decreased, okay? But yeah, that's basically it here, okay? All right, so the types of hemorrhages, we have 4 types. We have epidural, subdural, subarachnoid, and intracerebral. Subdural is the most superficial one, all right? It's above the dura mater, and as we know, the dura mater is the outer layer of the meninges. It's the third one, the one on the top, right? So anything above it is epidural hematoma. If it's under the dura, but above the arachnoid, it's called a subdural hematoma. If it's under the arachnoid, it's a subarachnoid hemorrhage. And if it's inside the brain tissue, it's called an intracerebral or intraparenchymal hemorrhage, right? Who can tell me what's this diagnosis? Oh, it's written right here. Can we hide this? All right, we can't hide this. It is subarachnoid. And the way you can tell it's subarachnoid is because you can see the grooves of the brain, right? Because the arachnoid covers the brain entirely, all right? So that the grooves in the brain will be filled with blood. And you're going to get a sign called the star sign light, right? Exactly, the star shape. Perfect. You're going to get the star shape right here, right? It's going to be white in color or bright in color. And bright indicates blood, right? And that's how you know that this is subarachnoid hemorrhage. These patients will probably tell you, I have severe headache. This is the worst headache of my life. They might have decreased level of consciousness. They might have a history of subarachnoid hemorrhage in their family, because one of the more common causes of subarachnoid hemorrhages is Berry's aneurysm, which could be related to familial diseases. Okay. All right. Another picture. Can someone tell me what's going on here? No, there's no edema. This is another subarachnoid hemorrhage, all right? If you look at the, exactly, it's another subarachnoid hemorrhage. You can see the grooves of the brain It's just it's probably artifact. The patient moved during the CT or something. All right, don't worry about this. But like if you look at the grooves in the brain, right, you can see that they are brighter, right? You can see that they are bright, and this indicates bleeding and probably subarachnoid because it moves alongside the grooves of the brain, right? See, as I said, B is not subarachnoid hemorrhage. B? What's B? Where's B? Oh, no, B is not subarachnoid. B is the norm. So this is just a comparison. So in CT, if we can tell between white and gray matter, we assume fluid. This is an edema testing. All right. Yes. If you can't differentiate between the gray and white matter, you assume that there's edema. All right, but not bleeding. Edema. Where's the star sign in A? All right. It's incomplete star sign. Like here, it's a complete star sign. All right. You can see it completely. Right. But here it's incomplete. Right. You can see that some of the grooves are filled with blood, but not all of the grooves. Not all of the brain grooves are filled with blood. So you get kind of like an incomplete filling. You don't have to get the star sign every time. All right. You're welcome. All right. So this is an epidural and a subdural. All right. One of the ways I remember is that the one that looks like an eye, all right, like when you look at an eye from the side, all right, you look at someone's eye from the side, it looks like this, right? Because it's like bulging, right? Just like that's how I know this is epidural. A subdural looks like a moon, right? Because it takes the concave. Lemon versus banana. That's another way. Yeah, that works. A lemon versus a banana. Yeah. So the one that is convex, the concave is a subdural. The one that is convex is an epidural hematoma. All right. And one more thing I want you guys to remember: you will never see an epidural hematoma that is from here till here. All right. You'll never see that. Why? Because the brain has sutures. All right. So like at some points there's like an attachment of the brain to the skull. All right. So like right here, there's an attachment, right here, there's an attachment, and so on. And if you have an epidural bleeding, all right, the bleeding is going to be contained between two sutures, all right? It's not going to cross suture lines, all right? You'll never see that the blood will start seeping right here, all right? Never in an epidural hematoma, because it's confined to the suture lines. But with a subdural hematoma, you can see that the hematoma starts from here and ends all the way here. Why? Because it does not respect suture lines. It crosses suture lines, all right? So keep that in mind. Who can tell me what causes epidural hematoma? Like what is torn in an epidural hematoma? What vessel is bleeding in an epidural hematoma? The middle meningeal artery, yes, all right? And since you said an artery, this means it's a high velocity bleed, all right? So these patients will present with an acute onset, right? So it's going to be very acute, like hours, maybe minutes, maybe it's going to be on the same day, right? They're going to die. If it's more than a day, they're dead, all right? The point is it's an arterial bleed. So when you see an arterial bleed, think of rapid deterioration of this patient, all right? In a subdural hematoma, what's torn? The bridging veins, right? And you guys said it, it's veins. And veins don't have high pressure, so they bleed slowly, right? So these patients can present to you after weeks. They can present after months, all right? And this is very common presentation in elderly patients who fall, all right? And then 4 weeks after that, they present to the ER with altered mental status, confusion, dizziness. They are wobbly, right? And you do a CT scan and you can see this, all right? So keep that in mind. In subdural hematomas, you can have a chronic subdural hematoma. All right. How is the prognosis? Epidural is way worse, but you need to keep something in mind that brain herniation and midline shift is more common with subdural hematomas. All right. So keep that in mind. But yeah. So in subdural hematomas, I said you can have acute and you have chronic, right? And when the blood is fresh, it's bright, right? You can see that it's bright right here because this is fresh blood. It's new blood. This is acute epidural hematoma, and this is acute subdural hematoma. If you get a chronic subdural hematoma, this line is going to be dark, right? Because all blood appears dark, all right? So keep that in mind. All right, what can you guys see here? Yeah, this is ischemia of the middle cerebral artery territory, all right? This is the anterior cerebral artery territory. No, it's not edema. This is an infarct, all right? And I'm going to tell you how to differentiate between ischemia and an infarct in a bit. So this is ischemia of the middle meningeal artery territory. This is probably not acute because you can see it on CT. Usually you won't be able to see it on CT if it happened like an hour ago or 30 minutes ago. Middle cerebral, not middle meningeal, right? So if it's acute, you usually need between 3 to 4.5 hours. Actually more, no, wait. 3 to 4.5 hours is the cutoff for treating stroke. But with a CT scan, usually it starts appearing by 6 hours, all right? So if you can see it on CT, it's probably too late a little bit, all right? But basically this shows you ischemia right here, right? And you can see that it's in the middle meningeal, cerebral artery territory. This is the anterior cerebral artery territory, and this is the posterior cerebral artery territory, okay? You can see here acute ischemic stroke, right? See here a middle-aged woman with few weeks of headache, nausea, and vomiting. What do you guys think this is? Okay. This is a brain tumor, all right? Because of one thing. And how can I tell it's a brain tumor? If you guys look at this part right here, right, you can see that it's not about the infiltration, it's about the contrast. This is a non-contrast CT and this is a contrast CT. And what you can see here is that the CT is being taken up by this mass right here. And the mass that takes up contrast means that this mass has vessels in it, has arteries and veins in it. And that indicates tumors, okay? Because abscesses only contain fluid and debris. They don't contain vessels, right? And that's how you know that this could be a potential tumor, all right? So the added contrast here. Yes, the added contrast to this picture right here. This is without and this is with. And you can even tell the added contrast because if you look at the CSF fluid, right here, the CSF looks dark, right? But right here, it appears a little bit whitish. All right. So these are the types of edema. Why can't you see the other vessels? What other vessel? Because they are not appearing on this cut of the CT scan. If you go down a little bit, you're going to because most of the vessels are at the base of the brain, right? And then they start branching. So these are the different types of the edema. All right, you have two types. You have cytotoxic and you have vasogenic. All right. Now, cytotoxic leads to loss of the white matter gray matter differentiation. So if you guys take a look here, right? Can you show me where does the white matter start and where does the gray matter start? Probably can't, right? Because well, I can't. But like if you look right here, you can see that this is the white matter, and you can see it starts becoming darker, right? So this is the gray matter right here. So here you can see the differentiation, but here you can't see the differentiation. And this is what we call loss of the white matter, gray matter differentiation, or the barrier differentiation. And this is characteristic for cytotoxic edema. All right. Now for vasogenic edema, the differentiation is still there. You can see it right here. All right. Why is it hypodense? Because it's water. All right. So edema is basically a collection of water, and water is dark. Like you can even compare it to the CSF. CSF is also mostly water, right? So you can also see it as dark if you look at the ventricles. All right. Honestly, I feel like this is too advanced for you guys. but this CT basically show you, this is a spine CT, all right? And it's showing you fractures of the C-spine. You can see that right here, there are fractures, right? You can see that this vertebra right here is also fractured. You sure between the two types of edema? Yes, of course. So to differentiate between vasogenic and cytotoxic edema, all right, there you need to look at one thing. Can you differentiate the white matter from the dark matter, all right, or the gray matter? If you can, all right, you can see the difference clearly, then this is vasogenic. If you can't see the differentiation, then that is cytotoxic. So take a look at this part right here and show me where's the white matter and where's the gray matter. You can't, all right? So this means that this is a cytotoxic edema, right? This is cytotoxic because you lost the differentiation between the white and the gray matter. But if you look here, all right, you can tell that this is the white matter and this is the gray matter. You can still see the differentiations, right? You can still see it. So if that is still there, then this is vasogenic. You're welcome. All right, so as I said, guys, this is just, I think it's too advanced, but anyways, this just shows you as a fracture of the C-spine. You can see that this vertebra right here is literally shattered in the middle, right here, all right? I can show you another fracture right here in the spinous processes of the vertebra, but there's nothing really that I can comment on more. The cervical spine, the spine in your neck. All right. What is this window? Oh my days, this keeps showing up. Yes, this is the lung window, because as you can see, everything else is white except the lungs, and you can see in details everything about the lung. You can see all the structures inside the lung. Everything is very clear when it comes to the lung structure, and that's how you know that this is a lung window. What window is this? Mediastinal window, yes. Soft tissue window, perfect. Yeah. What lung is this? What lung? What window is this? What can you see perfectly? What is very obvious on the CT scan? Like, yep, you can. It's the bone window. Thank you. This is the bone window, right? The only thing you can see here really are the bones, right? You can't really see the lungs. You can't really see the heart. I mean, you can tell this is the heart because that's its location, right? But there's something wrong with the heart. You won't be able to tell that there's something. So this is the bone window. What are you guys saying? Bone or heart? Yeah, it is bone window. Okay. So this is just different views. This is the soft tissue or the mediastinal window. This is the lung window, and this another lung window just in a different view. What is this view called, guys? Axial, coronal, what do you guys think this is? What is this called? This is a coronal window. C is a coronal window, and these are axial windows. Coronal views. This is a coronal view, axial view, right? Now there's another table I made, all right, for different diseases of the chest that you guys can go on and read. You have the aortic dissection, and one of the characteristics of aortic dissection is an asymmetrical blood pressure. Let me bold that for you guys. You can also have a tearing chest pain that radiates to the back. All right, this is also characteristics, all right, of aortic dissection. Right, aortic dissection is also very common in Marfan syndrome, and actually the most common cause of death in Marfan syndrome is aortic dissection. Right, you have pulmonary embolism, very common in hypercoagulable states like malignancy and pregnancy. Those are hypercoagulable states. So pulmonary embolism from DVTs are very common, right? Pleuritic chest pain is very common in these patients, all right? Pneumonia, obviously there's going to be fever, all right? And then you have pulmonary fibrosis, especially something very specific about it is non-productive cough, all right? So it's dry cough is very common. But yeah, you can go through this table on your own if you want to learn more about the presentation of each diseases. You know, sometimes I don't even need to look at the imaging thing. I don't even need to look at the X-ray or the CT. Like if I read the question, that's it. I know the answer. I don't even need to go through the CT scan. Yes, pleuritic chest pain is chest pain when you breathe. So when you take a deep breath, pain increases. You're welcome. All right. Moving on, middle-aged woman with shortness of breath for a few hours. What do you guys think is going on here? Pulmonary what? Embolism, yeah. All right. So if you guys look right here, right, in this pulmonary artery, right, and this pulmonary artery, right, it's so clear because of the contrast, and then you got this little black thing inside the pulmonary artery, and this is a pulmonary embolism, right? Again, another picture of a pulmonary embolism. This is a clear pulmonary artery, but then you look at this right here, you can see that there's this black thing inside the pulmonary artery, right? All right, what do you guys think is going on here? Pneumonia, right? Someone has fever, it's probably pneumonia, right? But this is not just only pneumonia. This is something called empyema, right? And so this is the lungs, and you can see that it's compressed. It's compressed from both sides by these black things. And these black things are what we call empyema. This is just a collection of pus and fluid and bacteria in the pleural cavity. It got so big to the point where it started compressing the lung tissue. All right. How to write that? Empyema. Is it mentioned on the next slide? Maybe it is. Yeah, right. There we go. See, empyema and pneumonia. Right. So this is the lung. This is the collapsed right lung, and this is the empyema. All right. Middle-aged man with upper back pain and dizziness. What do you guys think is going on? Aortic dissection. That's great. As I said, this is the pulmonary trunk, right? Or the pulmonary artery, right? And then you have the what? What is this? This is the aorta, right? And if you look at the aorta, you can see this small line right here. And by the way, you can't get embolism in the aorta, right? Like it's not going to be like this, right? So this is dissection, especially the presentation is an upper back pain, right? Back pain. Think of a dissection right here. And since this man is in middle age man, what do you think the cause of the dissection is? It depends on the dissection, all right? Because there are two types of dissection. You have type A and type B. Type A involves the ascending aorta. And if a dissection involves the ascending aorta, this is a surgical emergency, right? And this patient needs to go to the emergency right now. But if it's type B and it only involves the descending aorta or the aortic arch, you can treat it medically. But the presentation itself, it can be prolonged. Like it can be like 3 days ago, this patient started having this chest pain, all right? But it's gonna keep on getting worse till the patient knows that he or she needs to go to the ER. And it always looks like this on CT. Yeah, different variations, obviously, but like, yes, you're gonna find something in the aorta, right? You're gonna find 2 lumens in the aorta. That's how you say that this is dissection. You're gonna, that the aorta is split into 2 lumens, right? So it's now like, it's like 2 structures now. It's not only one aorta, it's like divided into 2. So you can see you have here the true lumen and the false lumen right here, right? Otherwise, you said hypertension. It's a middle-aged man. Do you think I have hypertension? See? Exactly. It's probably Marfan. All right. A young patient, middle-aged patient, it's probably something that this patient had min zaman or like grew up with, right? So it's probably Marfan syndrome or any other connective tissue disease, like maybe osteogenesis imperfecta or stuff like this. But it's probably Marfan syndrome. All right. But keep in mind, aortic dissection is a disease of the elderly. It's most commonly in the elder patient who has hypertension. All right. So keep that in mind. Yeah, aortic dissection. All right. 55-year-old male with shortness of breath for 6 months. What do you guys think this patient has? All right. This patient probably has fibrosis of his lungs. All right. CF as in cystic fibrosis. Well, is this a no, it's not cystic fibrosis. It's the patient is too old to have cystic fibrosis. All right. Cystic fibrosis patients are usually children. They're not elderly. And how do I know that this is probably fibrosis? Because of the duration of the presentation. You can see that this patient is having shortness of breath for 6 months, right? You can't have pneumonia for 6 months. Is the bulge in the middle normal? This bulge right here? Is this what you're talking about? They're near the aorta. Yeah, this is the aortic knob. It's normal. Yeah, it's the aortic knob. This is a normal structure. You're welcome. Right. So the length of presentation is very long for pneumonia. It's very long for any inflammatory conditions. It's very long for cancer even. Right. 6 months is very long. So this patient probably has pulmonary fibrosis, and you can look like throughout the lung field. You can feel that both lungs, the whole lung is affected. You can see that there's distortion of the lung parenchyma in all the lungs, on both sides. Right. Usually, if the patient has pneumonia, it's probably going to be on one side. It's going to be localized to one part of the lung, and so on. All right. But this is a diffuse condition. It's a diffuse pathology, and it's taking way too long for it to be anything but fibrosis. And if you do a CT scan, this is a normal lung. All right. You can see it's perfectly healthy. All right. But then when you look at that patient's lung, you can see these changes. And I'm going to talk about the changes that you can look at. All right.
We already know that the CT.
All right. So these are the changes you can look at. All right. You can see there are 3 things you need to look at. You can look at honeycombing, you can look at bronchiectasis, and you can look at reticulations. All right. Now, what is bronchiectasis? Now you have bronchus, right? You have a bronchus, right? If the bronchus becomes dilated, that's what we call bronchiectasis. All right. And if you look here, right here, can you see this one right here? This is a very dilated bronchus. And this is a sign of bronchiectasis. All right. This is just dilated bronchus. You can see it right here too. All right. A very dilated bronchus. That's bronchiectasis. What is honeycombing? Honeycombing is literally the formation of small pockets of air. All right. And you can see it right here. Can I zoom in? All right. Can you guys see this? Small pockets of air next to each other that resemble honeycomb, all right? And you can see it right here too. It's even better here, right? This is honeycombing of the lungs. And honeycombing is very specific to fibrosis, whether it's idiopathic fibrosis or fibrosis because of an inflammatory condition. When you see honeycombing, it's probably fibrosis. Now, what are reticulations? Reticulations are thin bands of fibrosis, all right? So you will see them, wait, right here. Can you see those bands of fibrosis? Like if you compare it to the normal lung right here, you can't see those bands of fibrosis anywhere. Those are bronchuses, by the way. These are terminal bronchioles, all right? But if you look right here, these are bands of fibrosis, all right? And this is what we call reticulations. It's just showing you the fibrosis itself. Can you repeat honeycombing? Honeycombing is the formation of small pockets of air. All right, they're small pockets of air next to each other. All right, and you can see them right here. See, this is one. This is another. This is another. This is another. And they're all next to each other to the point where they look like honeycomb. I don't know if you guys have seen honeycomb before. Get them from the process of fibrosis. So the fibrosis is gonna start separating the lung tissue shwaya, all right, until it starts forming those small pockets of air. This is what honeycombs look like, right? Let me see if there's better imaging. Look at this. This is amazing picture of honeycomb. Why is it not opening? Can you guys see this? This is a perfect look, perfect example of honeycombing. All right. Is honeycombing clear now? Okay, great. So that's what you see on pulmonary fibrosis. Okay. Now this is a splenic laceration, right? And you're gonna see just part of the spleen is darker than the other part of the spleen, and these you expect them in trauma patients. All right. So trauma patients will have this. Okay. Okay, so this slides basically tells you what you should take into consideration to choose the right imaging modality. All right, should I do an X-ray? Should I do a CT scan? Should I do an MRI? Whatever. All right, and this depends on the level of evidence available. All right, to answer a clinical question. So, for example, you get a patient that is unconscious, right? But you know that this patient was involved in a car crash or a car accident, right? And you auscultate this patient's chest. Right, and there is no air entry on the right side. What is the first thing you're going to order? And this patient is unstable hemodynamically. He's unstable. He is unconscious. He's hypotensive. Yeah, we'll order an X-ray, right? Why wouldn't you order a CT scan? Although a CT scan is a correct answer, it will show you exactly the timing. Exactly, it takes time. And you can't bring the CT machine to you. You can't bring the CT machine to the emergency department while we have portable X-ray machines, all right? So it depends on your clinical suspicion. It depends on what's available to you, all right? So keep that in mind. But yeah, okay, selecting appropriate. So define a clinical problem. Okay, so you need to know what the patient has. What is the patient complaining of, or what's abnormal in this patient, right? And then form a list of differential diagnoses, right? And then choose the appropriate modality for this patient. So, for example, if the patient has, okay, I have a question for you guys. If the same case I gave you, Minshwaya, was a pregnant lady, would you still get an X-ray? Yeah, you would still get an X-ray. No, you would get an X-ray, because right now the patient is dying. The patient is dying, right? And it doesn't matter if the baby is going to get a little bit of ionizing radiation. Who cares, right? I need to know if this patient has a pneumothorax or not. The benefits outweigh the risks. Yes, thank you, Lena. That's why you'd still get an X-ray. Okay, so keep that in mind. You need to use your clinical suspicion, all right? But let's say that a pregnant lady came to you, she's stable, but she's been complaining of 2 days of right lower quadrant pain. And you do a physical exam and this patient has rebound and guarding. Would you get a CT or would you get an ultrasound? You'd get an ultrasound, right? Because yes, it's true. The number one modality to diagnose appendicitis is a CT scan, but she's pregnant, right? And she's stable. If she's pregnant and she's stable, you don't need to expose her to CT scan. So you can do an ultrasound. Perfect. See, so you gotta also always outweigh the risks, right? So you need to know what do you have, what you can do, what you can't do, so you can choose the best imaging modality. Okay. And now I have some cases for you guys. We're just gonna go through them real quick. All right. So case number one is an 18-year-old male came to the ER with abdominal pain. All right. Temperature is 37.9. Heart rate is 80. The patient has right lower quadrant tenderness. What is the appropriate radiological examination? I would get a CT scan for this patient. The patient is a male, right? So he's not going to be pregnant. and he is stable. He is clinically stable. The only thing he's complaining of is a right lower quadrant tenderness. So what you would think of is appendicitis, right? And if you think of appendicitis, exactly, the number one imaging modality for appendicitis is a CT, probably with contrast. For appendicitis, you would get it with contrast. All right, you're welcome. So yeah, you will get a CT scan with contrast, and you can see it right here, this inflamed appendix. And how do you know it's inflamed? Because you will see that there's edema around the appendix itself. Like if you just zoom in a little bit, can you see this whitish hue right next to the appendix? This is signs of edema, right? And that's how we know that the appendix is inflamed. All right, so the clinical problem is abdominal pain. It could be appendicitis, gastroenteritis, or inflammatory bowel disease. Either ways, all of them will be diagnosed with a CT. Okay. Now, do you guys have any questions about case number 1? Great. Case number 2 is a 36-year-old male presents to the ER with right lower quadrant pain that radiates to the groin. The temperature is 37. Does inflammation here look like that in the brain? Do you mean the appendix? Is that what you're talking about? Fluid will appear dark, all right? And if you look compared to the walls of the appendix, right? The water or the edema is darker than the walls of the appendix, so it's darker, all right? But again, wait a second. Yeah, tamam? The edema, yeah, the edema is outside. It's around. It's specifically in the fat surrounding the appendix. You're welcome. Tamam. So for case 2, it's a 36-year-old male who presents to the ER with the right lower quadrant abdominal pain that radiates to the groin. The temperature is 36.8, heart rate is 80, CBC is normal, and urine test shows microscopic hematuria. What is the radiological examination? CT without contrast. What do you guys think the patient has? Yeah, the patient has stones, all right? What gave away that it's a stone because it's radiating to the groin, all right? So I don't know if you guys took that, but a stone has a presentation that we call from loin to groin, all right? So there's going to be pain that starts in the loin or the side of the body, and then it goes and radiates to the groin, okay? So that's how I know it's take GFR. You don't need contrast in a kidney stone because the kidney stone is inside the ureters, and you don't need contrast for that, okay? So either ways, even if the patient has good GFR and good kidney function test, you don't need IV contrast anyways. So you will go ahead and do a CT scan without contrast, all right? You're welcome. And there you go. Some will appear bright, so contrast. There you go. Another reason why we don't do contrast, okay? And you guys, you can see the stone right here. All right? Tamam. Renal colic, see the stone, urethric stone. Yep, we're good. Any questions about case number 2? Perfect. Case number 3 is a 28-year-old female who presents to the ER with abdominal pain. Her temperature is normal, her heart rate is normal, and she has right lower quadrant tenderness. What would you order? Okay. All right. Usually in the ER, you would get a pregnancy test first. Okay. You get a pregnancy test first because you don't know. She could be pregnant. All right. So what you do is you get a pregnancy test first, and then you choose a modality. What if you don't have a pregnancy test? What would you get? An ultrasound. Yeah. Okay. What else can you get? let's say you did an ultrasound and it didn't work, or like you couldn't see anything. Sure, you can shield her, but like when I say a shield, by the way, like there's still chance that the baby is exposed to radiation, right? Like a shield will decrease the amount of radiation, but there could still be exposure. Yes, Arul, you would get an MRI. All right, an MRI is a good option. It's a good substitute for a CT, right? Why MRI? MRI is better than CT scans, but one, it takes way longer. Wouldn't an MRI take? Yeah, it would take longer, but you don't care if it takes longer because she is hemodynamically stable, right? Like she's not, her life is not. Why is it safer? Because it does not use X-rays. MRI does not use X-rays at all. All right? Yeah, it uses magnets. All right, you're welcome. Tamam? So what you can get is an ultrasound. Wait, is this our case? Yeah. I don't know why she said CT with contrast, but ultrasound is the answer. Okay?
Excuse me?
Yeah.
I have a question about the case about the female. So if it's appendicitis, aren't we afraid that the appendix can rupture if we wait longer?
Yeah, of course, that can happen. The appendix can rupture if you wait longer. But what's happening right now, the patient is stable, right? Obviously, the first thing you're going to get is a pregnancy test. And if it doesn't work, or you don't have a pregnancy test, you get an ultrasound. The problem arises is that when the ultrasound doesn't show anything, the next best modality for a pregnant lady would be an MRI, right? That is the best. This patient has a chance of becoming emergent in any time, okay? But right now she's hemodynamically stable, and you deal with her as a hemodynamically stable patient. If she becomes hemodynamically unstable, that's a different story, all right? You would get an ultrasound. If it doesn't show anything, then you might consider CT scan with shielding, or you can go straight to surgery, right?
All right, thank you.
You're welcome. CT with contrast is what's used for appendicitis. Yes, CT scan with contrast is the imaging modality for appendicitis. It's the #1 modality. I agree with you. It's just the point is you still haven't figured out if this patient is pregnant or not. All right. If you haven't, then ultrasound is your first imaging modality, not CT. Okay. And actually, she shows you here an ultrasound. This is an ultrasound. Now, I don't have a normal one. Okay. But when you compare it to a normal one, this is the appendix, right? And this wall, this is the wall of the appendix, and it's way thickened. This is a very thick appendiceal wall, all right? And a thick wall indicates inflammation. So keep that in mind, okay? So you can see here that this wall is thickened. That's how you know it's inflamed. Do we have any questions about the third case? Great. Oh, see, she did an MRI. Right. She did an MRI, and that's a baby, by the way. And if you guys look right here, okay, you can see that this is the wall of the appendix right here. And you can see that there's fluid collection around it, right? There's this hue around it, and this is edema, okay? This is edema around the appendix. So that's how an MRI looks like. Case 4 is a 36-year-old slim and tall male. Slim and tall male. What do you guys think when I say a slim and tall male? What do you start thinking of? Yeah, okay. I know it's cliche and you shouldn't do that, but like in a question that says a slim and tall male, like there's no reason they would mention that this patient is slim and tall unless they're trying to tell you something, okay? And they're trying to tell you that this patient might have Marfan syndrome, right? But anyways, one thing I need you guys to remember, in a patient who's slim and tall, even if they don't have Marfan syndrome, they have a higher chance of getting spontaneous pneumothorax, okay? So keep that in mind. That's just a piece of information that I want you guys to remember. Now, a 36-year-old slim and tall male presents to the ER following a multi-vehicle accident with headache. So the patient has a headache with several episodes of loss of consciousness, followed by regaining of consciousness and chest pain. Temperature is 37.2, heart rate is 120, and BP is 140/98. The patient has right mydriasis and absent right lung sounds. What is the best imaging modality? Tasneem said full CT, and I agree with you. I think you should get a full CT. What do you think this patient has? What is mydriasis? Mydriasis is dilation of the pupils. So the patient will have one pupil that is blown out or very dilated, and the other pupil is normal or constricted, right? And that is mydriasis. Meiosis is the opposite. It's very, very small. You're welcome. An X-ray, sure. But if you look here, this patient has two problems, right? The patient doesn't have one, he has two. He has loss of consciousness, he has a headache, all right? And he has regaining of consciousness. So he loses consciousness and then regains consciousness again, right? And this patient also has chest pain, right? So he has problems in two systems, his head and his chest. He has signs and symptoms of a stroke, and he has signs and symptoms of a pneumothorax, not aortic dissection. Absent right lung sound, so the lung is affected. And in a motor vehicle accident, you would think of what? What lung pathology you would think of in a motor vehicle accident that gives you an absent right lung sound?
Tension
Pneumothorax. Pneumothorax is your number one. Hemothorax is another answer. Pneumonia is not going to happen in a car crash. So keep that in mind, guys. This patient probably has a pneumothorax, and the patient also probably has a bleeding in his brain. So what you will get is a pan-CT scan. What is a pan-CT scan? I think one of you guys mentioned, I think it was Tasneem, right? A full CT scan, a pan-CT scan of the whole body, head, chest, abdomen, pelvis, everything. If it were hemothorax, would you hear crinkling? No, you would not hear crinkling. You will hear absent breath sound. There will be no breath sounds. But how do you differentiate between pneumothorax and hemothorax? Is that when you percuss, pneumothorax would be hyperresonant because there's air inside. So you'll have hyperresonant percussion, but with hemothorax, you will have dull percussions because there's blood inside. You're welcome. Okay, Lena says this is an epidural hemorrhage. What do you guys think? Okay. Yeah, this is an epidural hemorrhage because it's a lemon or eye from the side, right? So it's bulging inside. This is an epidural hematoma. Okay, exactly. It's convex. And what is this? What is this right here? This is a pneumothorax. See, this is very dark, indicating air, and you can see that the lung is compressed. All right, the lung is pushed down by this air right here. So this is a tension pneumothorax. What do you guys think this is? This is dissection. If you look at the aorta, you can see that there's two lumens inside the aorta. And if you guys remember the type A and type B pneumothorax dissections that I talked about, remember? This is a type A aortic dissection. Why? Because it involves the ascending and the descending aorta. All right. So this is a straight to surgery kind of case. Then this is a type A aortic dissection. Right, so you can see that this patient has here an epidural hematoma. This patient has dissection. This patient has pneumothorax, and yeah, so a pan-CT is the right answer for this patient. Type P is only descending or the aortic arch. What differentiates between type A and type B is the involvement of the ascending aorta. If it involves the ascending, it's type A, and this is surgery. If it involves the descending or the aortic arch, this could be managed with medications. You're welcome. All right, so we're done with this lecture. Do you guys have any questions? All right. Do you want to take a 5-minute break? Okay. See you guys in 5 minutes. All right, guys. We technically have one lecture to go, because as I said, the last lecture is not, there isn't really a lot of things I can talk about, but I'm just going to go through it real quick in case you guys have any questions. All right, so let's start talking about the ultrasounds. Is this the ultrasound lecture? Yeah, this is the ultrasound lecture. All right. Okay, so as the name implies, ultrasound uses sound waves, right, to create an image. And I'm going to show you how that happens, right? And I need you guys to remember that the wavelength of ultrasounds are way longer than X-rays and CT scans, because in X-rays they are on the other side of the spectrum of the waves, right? They are high in frequency and low in wavelength or magnitude. Right? And in ultrasounds, it's on the other end of the spectrum, where they have low frequency and larger or bigger wavelengths. Okay. So this is just an explanation. This is a high frequency wave, right? And this is a low frequency wave. And when you put them, actually, let me show you a picture. Electromagnetic spectrum. Why are these not opening? You can see it right here. See where X-rays are? X-rays will be right here, and you can see that they have a higher frequency, all right, and shorter wavelengths. While ultrasounds are on this side of the spectrum. They have shorter frequencies or lower frequencies, and they have larger or bigger or wider wavelengths. Okay, and the higher the frequency is, or the faster the frequency is, the more ionizing and damaging radiation it is for the patient. So you can see that gamma rays are right here, and gamma rays are what you can see in uranium and stuff like this. This is very damaging to the human being. Now, the lower you go, the better it is. You can see that microwaves are here. Okay, so yeah, that's basically what this says. Now, the velocity is constant for specific waves. Honestly, I feel like this is all just gibberish. I don't think you're going to get tested on this. It's a basic formula that tells you that the speed of the sound, all right, is equal to the wavelength multiplied by the frequency. All right, so you just the frequency, like, okay, so you take this right here, you can see that the frequency is 2 multiplied by the wavelength, or the distance between 2 waves, and this is the speed of the sound. Okay. Honestly, I don't think you need to remember anything about this. It's just there. Again, the higher the frequency, the shorter the wavelength, the lower the frequency, the longer the wavelength. The sound that humans can hear are generally in the ranges of 20 kHzs, right? While ultrasound are way higher than this. It's the opposite. This is supposed to be characteristics. Yeah, it's just characteristics of ultrasounds, that's it, okay? While ultrasounds are in the megahertz, right? So we can't hear them as humans. You can't hear the ultrasounds, okay? So ultrasounds are less than the audible sound, okay? So in the wavelength, the ultrasounds are shorter than the audible sound, but the energy is higher than the audible sound, because the frequency of ultrasounds are higher than what we can hear. Okay. Again, same thing, no difference. Okay. Now this is actually how the image is formed. I need you guys to know Ultrasound uses sonography. Yeah, it's the same thing. When you hear sonography or ultrasounds, they're synonymous. They're the same thing. Okay. There's this one picture I want you guys to see. Yeah, this picture right here. Okay. Now, this is the transducer of an ultrasound, or the handle of an ultrasound. And the most important part of it is the piezoelectric crystal, this crystal right here. And one of the characteristics of this crystal is when you give it electricity, okay, it vibrates. And how are sound waves made, or how are sound waves created? Sound waves are created by vibration, right? So when you vibrate, you get sound waves. And that's how ultrasound works. When you give a current or electricity to this piezoelectric crystal, it starts vibrating really quickly, which gives you ultrasounds or sound waves, okay? Now, when those sound waves hit the organs and then they are reflected back, they are hitting the piezoelectric crystal. And one of the other characteristics of piezoelectric crystals is that when they vibrate, they give you electricity back, okay? So it's a two-way street. If you give it electricity, it gives you vibrations. If you give it vibrations, it gives you electricity. Okay, and that's how an image is reflected back on the crystal, right? So the sound waves that, can you please repeat it? The ultrasound. Okay, so you have the crystal, right? And you gave this crystal electricity. How are ultrasounds formed? When you give it electricity, it starts vibrating. The crystal starts vibrating. And when it starts vibrating, it gives you ultrasounds. Now, those ultrasounds are going to travel and they're going to hit the organs inside the human body. When they hit the organs inside the human body, they are reflected back. Okay? So they hit them, and then they reflect back. When they are reflected back, they hit what? The crystal. They hit the piezoelectric crystal. And as I said, when the sound waves hit the piezoelectric crystal, they make it vibrate again. And when it vibrates, it gives you electricity. Okay? And this electricity is taken to a computer, and a computer reads this electricity as an image. Okay? Was that clear? How do we make sure the waves hit the organs so we're targeting and not something in front of them? So you put the transducer right on the organ that you want to visualize. So if you want to visualize the liver, you put it on the right upper quadrant, right? So it's immediately on the right upper quadrant. Now at the beginning, you're going to see the skin, you're going to see the adipose tissue, but right under the adipose tissue, you're going to start seeing the lungs. The liver, right? And that's how you see. So you wanted. No, the connective tissue will be visible, right? But they're going to be on the top, because the top is the skin, then the connective tissue, then the subcutaneous fat, and then the organ that you want to see. Okay. So if you look right here, right, see those. This will be like the skin, and then you're going to have the fat, and then the connective tissue, and then you're going to see the organ you want here. So it hits the organs, then back to the piezoelectric crystal. And when you hit sound waves or you hit vibrations with the piezoelectric crystals, it vibrates, right? When it vibrates, it gives you electricity. So it has a dual function. If you give it electricity, it gives you vibrations. If you give it vibrations, it gives you electricity. You get the point? And then the electricity formed will be sent to the computer, and the computer will give you an image. All right. So that's the transducer, right? You're welcome. That's basically the same explanation, right? It's a two-way street. It's a two-way mechanism. All right. That's basically what it explains here. Yep. Same thing. Acoustic impedance is basically tells you how different parts of the body absorb or reflect back ultrasounds differently, all right? That's basically what acoustic impedance is, or how ultrasounds travel through this organ specifically, all right? So for example, it's not gonna travel through bones, right? It's gonna be all reflected back to the probe, right? When it hits bones. That's why it's gonna appear very white, because all of the ultrasounds are back to the transducer. But if it hits the liver, which is a soft tissue, some of the ultrasounds are gonna pass through the liver, and not all of them are gonna be reflected back. So the liver is gonna be darker, because not all of the ultrasounds went back. Some of them just went through or got absorbed. That's basically what this slide tells you. Now we have propagation of the ultrasound in the media. Okay, so when the ultrasounds leave the probe, things can happen, all right? One of them is reflection, the other is refraction, and then the third one is scatter, okay? Now, if you can, guys, some of them will be absorbed right here, right? They will never make it back to the transducer, right? They're just absorbed. Reflection is that when it hits the organ, it goes back straight to the transducer, all right? It's just hits it and goes back to the transducer. Nothing else happens. It doesn't get absorbed. It doesn't get refracted. It doesn't get scattered. It's just reflected back. And this is what happens with bones and needles and stuff like this, all right? Or they can scatter, all right? And by scatter, they go, you guys remember yesterday's lecture? They just go right and left, right? And they don't contribute to the formation of the image. They're just scattered. And then the last one is refraction. So like if you point it directly at the liver, right, the angle changes because the light or the sound waves got refracted. Okay, if you can look at right here, see, it goes in a straight line, hits the organ, and then it's refracted. Okay, it just changes direction or changes the angle when it hits the organ. Okay, so attenuation depends on the loss of energy. So as I said, yeah, what about refraction? It gives you a different angle, right? So like it's not going to be a straight image of what you're seeing right in front of the probe, okay? So it's just a different angle. You're going to have to manipulate the probe more to get the angle right, okay? Exactly like light in water. It's exactly the same thing. Not distorted, it's just in a different angle. So like if you want to get a part of the, okay, I don't know how to explain it. Okay, so this is the liver you're trying to see, okay? And if you point it directly like this, and there is refraction, what you're gonna see is gonna be this angle. You're gonna see this part, right? Or whatever is next to the liver. You're not gonna be able to see the liver or whatever you're trying to see in the liver. So to get the angle right, you're gonna have to manipulate the transducer or manipulate the probe to eliminate the reflection, all right? You're welcome. Attenuation is loss of energy, as I said, okay? So there's no loss of energy when it hits the bone because everything that hits the bone will be reflected back to the transducer. So this would probably be bone, okay? Now the attenuation differs when you lose the energy of the sound waves, and you lose the energy of the sound waves when they pass through organs. Now they can't pass through bones, right? So they are reflected all back. So you don't lose energy. But when they pass through something like the liver, some of them are absorbed, some of them are stopped, right? And that's how you start losing energy in sound waves. And that's what gives you different attenuations in the image. All right? Again, reflection increases with air and bone. Nothing really to talk about here, you know? It's the same thing. Again, reflection. This, by the way, shows you a needle. If you can look right here, you can see a needle right here. All right. Okay, so in air, how can I explain it? Air, think of it as a vacuum, all right? Or think of it of like the ultrasound won't have anything to bounce off in air, right? So it's going to be completely dark, all right? So like, there's nothing for the ultrasounds to bounce off. You're welcome. What is the needle for? It's probably a diagnostic or a treating process. So for example, a fine needle aspiration, this is an ultrasound guided biopsy, an ultrasound guided procedure, right? That's when we use needles. Right. So for refraction, yeah. White time waves comes back into the computer. Honestly, I don't know what this slide's trying to say. It's basically the same thing. It gives you something that is not true, or the light is not like it's what you pointed your probe at is not what you're looking at. Okay, it's something else because the light is giving you a different angle. That's basically what the slide's trying to tell you. Again, the transducer. Okay, so we have a contrast resolution, spatial resolution, and temporal resolution. Again, now here, it's basically the same thing, right? But there are some things that I need you guys to focus on, right? And by the way, here we measure it by decibels, right? So the attenuation measurement unit is decibels. If you guys remember in CT, it was Hounsfield units. Here it's decibels. Okay. All right. So in the axial, you have two types of resolution when it comes to spatial resolution. You have the axial resolution. You have the lateral resolution. Okay. The axial resolution relates to the wavelength of the ultrasound itself. And the shorter the wavelength is, the higher the spatial resolution. So if you want to get better spatial resolution, what you can do is you increase the frequency of the ultrasound. So you increase how frequent they are, And when you increase the frequency, what do you decrease? You decrease the wavelength, exactly. It is technically opposite to X-rays, yes, but they are two different, modalities. So don't try to mix them together. But yes, technically, yes, they are different to each other. So in axial resolution, for an axial resolution, if you have a shorter wavelength, aka higher frequency, you get a better spatial resolution. So you need to remember this. For the lateral resolution itself, it doesn't have anything to do with sound waves, but it depends on what type of piezoelectric crystal you're using. There are different types, and there are higher quality ones and lower quality ones. This is more technical issue. You don't really need to know it yet. But the one you need to focus on is the axial resolution, and you need to remember that the shorter the wavelength is, the higher the frequency, the better your spatial resolution is. Again, it's the same thing. The axial resolution increases with the frequency of the transducer. You increase the frequency, you increase the axial resolution. This is just an example. If you look, this is a 4 milli. Why did I fucking stutter? All right, this is 4 MHZs, right? And this is 6. And you can see that the one with 6, you can see better quality or better differentiation of structures when you increase the frequency. Okay, so when you increase the frequency, you can see better. You can see the structures better. You can differentiate between them better. Right here, not so much. You can still see a lot of things, but the differentiation between structures is poor. All right, now we're talking about conditions or the clinical application of some of these stuff. Do you guys have any questions in the physics? The most important thing you need to remember is the piezoelectric crystal and how it works. And you need to remember that the spatial resolution is better with shorter wavelengths and higher frequencies. So that's what you need to remember from the physics, basically. You're welcome. تمام. Now we're talking about clinical ultrasound. تمام. You have hemangiomas. Hemangiomas is basically a benign lesion that is made up of blood spaces or spaces that is filled with blood. Okay, it's proliferation, abnormal proliferation of blood vessels. Okay, and they're collected كده مع بعض into a ball. All right, and this is how it looks like. All right, and although it's filled with blood, تمام, it will look isoechoic, or it will look just like the structures near it. But you're gonna notice that there's distortion. You're gonna notice that there's a mass right here. Okay. You guys know what posterior enhancement is, or posterior acoustic enhancement is? No. A posterior acoustic enhancement is if you have a fluid, or if you have an abscess, for example, that is filled with fluid. When you put light through it, when light goes through it on this side, it's going to come on the other side brighter. So you're going to have a shadow that is brighter than the one that was sent. So if you guys look right here, okay, look at this one right here, you can see that behind it, it got brighter. So this tells you that this area right here is filled with fluid. So when it enhances, when it becomes brighter, that's how you know that this cavity right here, or this mass right here, has fluid inside it. Was this clear? Okay, and this is what we call posterior enhancement. Okay, hemangiomas are a collection of blood vessels that have grown randomly or chaotically. And they appear echogenic, or they appear as the same or almost similar to the normal tissue. Okay, so they appear almost similar to the normal tissue. You have something called anechoic, okay, and then you have something called hyperechoic. Hyperechoic is when this mass is way brighter than the surrounding tissue, and anechoic means that this structure is black compared to the surrounding structure. And then you have hypoechoic. Hypoechoic means it appears darker. Darker doesn't mean black, it just means that it looks darker. So you have hyperechoic, looks brighter. You have isoechoic, it means it looks the same color. And then you have hypoechoic, means it looks darker. But then you have anechoic. Anechoic means it's black. And hemangiomas appear either isoechoic or slightly hyperechoic. Tamam? And why would they appear slightly hyperechoic? Because they are filled with blood, and blood is fluid, and fluid enhances the sound waves. They make them brighter. Tamam? You're welcome. Sorry, blood does, not fluid. Tamam. Now let's talk about the gallbladder شوية. What is the most common cause of an ultrasound? Like, why would you order an ultrasound for a gallbladder? What's the most common reason? Cholelithiasis, right? Or gallbladder stones. That is probably the most common cause. Cholecystitis is also another cause. And if you look at a normal gallbladder, the two ways you can assess a gallbladder is by the presence of edema around the gallbladder and the thickness of the gallbladder wall. This is a normal thickness of a gallbladder wall right here. In cholecystitis or in cholelithiasis, the gallbladder wall will appear thickened. Okay, anytime there's an organ and that organ has a covering and that covering is thickened, there's inflammation. So in cholecystitis, the gallbladder wall is going to be thickened and you're going to have edema around it. Also, you're going to find a stone inside the gallbladder. And this is a stone inside the gallbladder right here. How can you tell this is a stone? Is edema dark? Edema is fluids, right? Sure, we don't use ultrasound to see. The thing is, no. Edema is a collection of what? It's a collection of fluids. and fluids appear dark. But it's not, edema is not frank fluids. Like it's not a collection of fluids only, right? Because if it was a collection of fluids only, it's going to appear absolutely dark. It's fluids within the tissue. So it's going to appear hypoechoic. It's going to appear darker than the normal tissue. But it's not going to be black. You're welcome. Now, this is a gallbladder stone because, yes, it is bright, but also because something we call, okay, so you have two things. You have a posterior enhancement, okay? And then you have a posterior shadow. You have acoustic enhancement and an acoustic shadow. Acoustic enhancement means that this is filled with fluid. The fluid made it brighter, so it became enhanced. So this is posterior enhancement. But if it's a solid, if it's a stone, it's not going to allow for the flow, for the wavelengths or the ultrasounds to pass through it. So you're going to get a posterior shadow. And this is what the posterior shadow is. Look at this dark shadow right here. This is because the ultrasounds did not pass through the stone, okay? And this is what we call a posterior shadow. And that's how we know this is a stone, okay? And you can look here, there's multiple stones here. And how do you know that these are stones? Because no ultrasound passed behind them right here. See, it's all dark. All right. Again, this is a normal ultrasound of the kidney. And if you look right here, there's a stone right here, and you can see posterior enhancement right here, posterior enhancement. Right under behind the stone, it's just dark, and this is posterior enhancement. This is a case of hydronephrosis. Guys, what is hydronephrosis? Kidney big, basically, yeah. Yeah, sorry, I mean a shadow. There's a posterior shadow. Now, if you know how the kidney is connected to a ureter, right? If the ureter is blocked and the urine starts backing back into the kidney becomes dilated. Okay, and that's what you see. The calyces and the pyramids of the kidney becomes very dilated. And this is what you see here in this ultrasound. You can see that these calyces are very dilated. Compare them to this one. You can see they are very small. صح? See, small finger-like pyramids and calyces and pelvis, right? Then compared to this one, it's very dilated, very dilated. Okay, and this is how we know this is hydronephrosis. Any questions about hydronephrosis, renal stones, and gallbladder stones? Great. Yeah, let's stay with you. Almost done. All right. So thyroid is like probably the hardest thing to visualize on an ultrasound. I'm not really sure what she's trying to tell you here, but this is how a normal ultrasound looks like, I guess. Honestly, I don't know what to explain here. Like, okay, how do you know that this is a cyst? This one right here. How do you know that this is a cyst and this is a cyst? How do you know? Exactly, the enhancement behind it. See, it got brighter right here, like compared to this area right here. See, this is brighter. That's how you know it's a cyst. It's a cyst because it's filled with fluid, and the fluid enhanced the ultrasound. Now, how? Yeah, this is. Yep, you guys can read this. But yeah, I highly doubt she's gonna dig deep into thyroid ultrasound, but this is a very good summary of what this picture shows you. Now, how do you know that this is a nodule? How do you know this is a nodule or cancer, basically? It's isoechoic. Yeah, yes, that's a very good explanation. It's isoechoic, and if you go behind it, compare this area to this area, there is no difference. There is no difference. There is no posterior enhancement or posterior shadow. Okay, and that's how you know that this is a mass. This is a tissue. You know? This is not a stone, and this is not fluid. This is a mass, piece of mass of tissue, and that's why we start thinking about thyroid cancer in this case. There is no shadowing. So if it's a part of the body, if it's a tissue, okay. So like let's say it's thyroid cancer or liver cancer or whatever, it doesn't contain fluids, but it also doesn't contain something solid like a stone. So you won't have posterior enhancement and you won't have a posterior shadow. You're just gonna have a normal background. It's not gonna enhance and it's not gonna be shadowed. And that's what you see here. If you compare this area right here, which is right behind, not right behind this, and then you compare this area right here, there is no difference. And that's how you can tell there is no shadowing, and also there is no enhancement of the shadow. Was this clear? Normal organs do look this way, exactly, right? And if you didn't see that there is if you didn't see that there's like something like a capsule or like a differentiating line between the normal structure and the cancer, you would think that this is normal. But because you can see that this is obviously a mass, right? This is obviously something that does not belong to this area, you should start suspecting that this is cancer. But because there's no enhancement and no shadow, you can cancel out abscess or a cyst, and you can also cancel out stones. We good? I'll assume we're good. Okay. So capsule plus the fact that it acts like normal tissue. Yes, it looks like normal tissue. It doesn't act like normal tissue. It looks like normal tissue, but it also obviously looks like a mass. It looks like it's something that doesn't belong there. This is just the adrenals. The adrenals sit on top of the kidneys. They have an inverted Y shape, right? So like this is a Y. They are like this. I don't know how to explain it. It's like, wait, let me just show you a picture. I'm pretty sure you guys saw one. These are the adrenal glands right here. So if this is a Y, this is an inverted Y. So this is what you see on adrenal. You can see that this is the kidneys right here. And it sits on top of it right here. This is the kidneys. You can see here the pelvis, the calyces of the kidney. All right, you can see this is the pelvis right here. It looks huge here, actually. Yeah, I'm not sure what is going on here, but this looks like a very huge adrenal gland. Wait, where's the baby? I have no idea where's the baby. But like, look, this is the liver, guys. This is the liver. So you can see that this is the kidney, and this is the liver right here. Because the liver and the kidney, they sit on top of each other. And you can see that this is the adrenal gland. This thing right here is the adrenal gland. And we're done. Any questions about the ultrasounds? Why is it black? I'm not sure, honestly. No, not really sure. Sorry about that. Let's read the Can see liver and kidney and adrenal glands in between. The kid usually has higher probe frequency. You can see all details anterior and posterior. Yeah, it doesn't really show. I'm sorry. All right. Tamam. Then we have the last lecture. Let's get this over with. Guys, honestly, do you want me to go through it? Honestly, it's just straightforward. It tells you what the patient, when the patient should start fasting before a procedure. So for example, if you go here, right? Where is it? A colonography. In a colonography, it tells you that the patient should start fasting 2 days prior to the exam. The patient has to be on liquid diet, so only juices, clear soup, water, stuff like this, right? And then the day prior to the exam, the patient has to take gastrographin at 18 hour and then drink 2 to 3 liters of water. Honestly, we didn't take this. Like, it wasn't in our curriculum back then. This is the first time I see this lecture, by the way. Like, even the last 2 years, I did not see this lecture. So I'm not sure if you should remember all of this, but I don't know, honestly. You know, the problem is there's nothing for me to explain. That's the problem. Like, there's nothing for me to explain. Like, it's just pure memorization. That's the problem with this lecture. It's not in the previous batch. Yeah, see? Because I gave the crash course for the past 3 years. I would know if this was there, but like, it wasn't. So I'm not really sure if I should give it to you guys. Hafin, if you go through it, it's literally just memorization. Like GI fluoroscopy, see? The patient should not have anything to eat or drink prior to the midnight. Okay, what am I supposed to explain? And then you go to small bowel series. The patient should not have anything after midnight. Okay, like, sure. So, yeah, it's just memorization. If you guys wanna email me, this is my email, right? Wait, let me type it in the chat. No, what apps will? Chats. Okay, this is my email. If you, oh wait, Al-Faisal, no, not what Gmail. Maklad at alfaisal.edu. Okay, this is my email in case you guys have any questions regarding this lecture or any other lectures. Anything that is not clear, please do email me whenever you want. It's also my phone number. So this is my phone number too. All right. If you want to email me, text me, call me, whatever, I'm always available. All right. I have chronic insomnia, so you can call me at 5 a.m. I'll be up. And yeah. Thank you so much for attending this lecture, and I hope it was beneficial. And I hope you do amazing on your radiology midterm and final. You are very welcome. Of course. I'm glad to hear that. Okay, guys. Take care, and yeah, please don't hesitate to contact me.